Ever notice someone dragging large black bags through the hospital lobby and wonder who they are? That, my friend, is a medical device rep. Welcome to Device Guys. Your hosts, Brent Lloyd and Jason Doliak, bring 50 years of combined medical sales experience to the table, sharing insights, stories, and a behind-the-scenes look at this fascinating world. Enjoy the conversations.
When you started the TAVR program, it was at Intermountain Medical Center. It was one of the, you had been involved in like appendage closure, right? And that, but TAVR came to market before that did. Talk a little bit about what, we've talked about TAVR on the show. People should know what it is, but we're replacing an aortic valve with a catheter. Why don't you talk about how, the whole lead up to that, like the studies and the things that you were doing?
Yeah, so we started doing left atrial appendage closure in 2005. In fact, I kind of brought that over from the University of Utah when I came to LDS and got going on that. We did our first MitraClip for repairing the mitral valve with a catheter in 2007. And then we were invited to be part of the partner trial, which was the initial trial of transcatheter aortic valve replacement, or TAVR, and did our first one in 2009. It was a different procedure then than it is now. These were big devices. We didn't really know what we were doing. We didn't have CT measurements for sizing. We had a lot of complications.
Talk about the patients. What type of patients were they?
There were two trials that were done simultaneously. We called them Partner Cohort A and Partner Cohort B. Partner Cohort B were patients where the surgeon felt like they could not operate on them, and they were randomized to medical therapy versus device. And, we all were saying the patients with device did so much better. It was obvious to us the benefits of TAVR then, and it was so hard to randomize patients. It's like we're randomizing them to life or death. And that was really what we knew was happening. And in fact, when the results came out, we saw this dramatic 20% survival advantage doing the procedure very quickly compared to medical therapy, where patients just died so aggressively. So it was just a earth-changing experience to be involved in that and see the benefits to patients. And then we had these very high-risk patients who were randomized against surgery. And once again, we saw the benefits of a less invasive procedure for these elderly patients. And these benefits were even with rudimentary valves compared to what we have now and limited experience. But I think we've all recognized that one of the big advantages and tremendous learnings of TAVR was how it brought together the heart teams. And this is where I had a tremendous partner as I started doing this, and a surgeon named Kent Jones. Mm-hmm. And, Kent was such a hero where...
Legend.
He was a legend, and he is a legend, and a friend and a gentleman, and most of all, just a patient's doctor who was always trying to do the right thing and take care of patients and set a tone for our institution about bringing a team together to do the right thing.
We should get KJ on.
Right?
That'd be a good
That'd be a good episode.
He would be awesome.
For sure.
Yeah.
And talk a little baseball.
Right? All the things. Yeah. No, that would be great.
Yeah.
Speaking of silky tones, Kent Jones's voice, man. That guy,
right?
That guy's got that deep, silky tone.
Maybe we should have him do an intro for us instead of Mike Whitlock.
Oh, don't
Can you hear that?
Don't hang out, Mike Whitlock.
Right?
So we talk about these valves, and I don't know that everyone really knows about what are we treating, like the disease of aortic stenosis. How does that progress? And I'm really asking for me, because I'm in the pacing world. I basically have worked tangentially next to you for the last 2 decades. But as far as aortic stenosis, help me understand, or help the population understand, kind of how does this progression happen?
Yeah, this goes back to a Dr. Brownwald, who was a legend and publishing in the 1960s, showing how patients get worse somewhat slowly, and then they fall off a cliff where they get into real trouble, and it's a very fatal progression if patients are not treated for their aortic stenosis. So, and we have more and more evidence of the benefits of treating aortic stenosis in patients, so it's powerful intervention.
Is the pathophysiology of that aortic stenosis development, is it just calcification? Is it calcification over time? Is it afterload? Is it preload? What are we seeing that actually, it leads to this stenosis?
Yeah, aortic valves become calcified and rigid and don't open, and that puts a strain on the left ventricle, and over time the ventricle fails, and then patients really die with florid heart failure in a terrible way.
Heart valve failure leads to heart failure. Jason.
There you go.
Yeah, there you
That
go.
Like you've said that before.
sounds like
That was maybe not the first time you
I
said
mean,
that.
I like valve attack better, but
Valve attack.
heart valve failure is pretty scary
Pretty good.
too.
No.